We'll continue with the sepsis topics now. So the first topic here, so I'll be discussing about four important topics. One is the PK/PD of antibiotics in critically ill patients, aerosol or inhaled antibiotics, fungal biomarkers, and how to manage invasive fungal infections. Okay. So first is PK/PD of antibiotics in critically ill. So in this, which is only relevant for the critically ill and for your exams, I have discussed, because this topic is actually a huge topics. Okay, it will take around 1.5 hours, 2 hours. Okay, because if I have to go in detail about what is absorption, what is elimination, so what drugs are time dependent, concentration dependent, I'm not going to discuss any of these. Okay, these are very basics. So knowing that you people know about it, I'm just discussing some important relevant things which you need to write in your exam. Okay. So coming to the introduction. So the treatment of critically ill patients, it poses unique challenges, particularly during the management of infections. And antibiotics play a pivotal role in combating infections and improving the patient outcomes. However, the pharmacokinetics and the pharmacodynamics of antibiotics in these critically ill patients, they differ significantly from those in the general population. Why it differs? Because there is an altered organ function in critically ill patients. There are changes in tissue perfusion. There is variations in fluid balances. All these can affect your pharmacokinetics, especially your drug absorption, distribution, metabolism, and the elimination. Hence, traditional dosing regimes may therefore achieve inadequate therapeutic drug concentrations in critically ill patients. So basic concept, yes, what is pharmacokinetics? What the body does to the drug. And pharmacodynamics is opposite, what the drug does to the body. And the four important pharmacokinetic processes are absorption, distribution, metabolism, and your elimination. Okay. Now, this is the one which you need to write in your exams. What are the pathophysiological alterations that are seen in ICU patients, which is actually causing inadequate drug dosage in the ICU? Okay. So, the first important pathophysiological change is changes in your volume of distribution. So, volume of distribution is the thing that when you give a drug, how much amount of the drug is going into the tissues. So how much is it distributed? Okay. So what causes the changes in volume of distribution? The first thing is your sepsis. Okay. In sepsis, there is increased vascular permeability and edema, which leads to substantial transfer of fluids from the intravascular compartment to your interstitial space. So when this occurs, your volume of distribution increases. That is the first cause. Second, most of the ICU patients have presence of any pleural effusions, ascites, and some surgical drains, all of which may also cause increase in your volume of distribution. Second and most important cause is your hypoalbuminemia. So what happens in hypoalbuminemia? There is increased fraction of the unbound drug in the blood. So when there is increased fraction of the unbound drug, it gets freely distributed to the tissues. So this also increases the volume of distribution. Now, why I'm so worried about the increase in volume of distribution? Because this increased volume of distribution causes decrease in the maximum plasma or serum drug concentration. That is, there is a decrease in your Cmax and the total drug concentrations over the. So this may lead to potential underdosing, and it usually provides subtherapeutic concentrations. So in such cases, an increase in the dose may be necessary during the initial phase of treatment, and adjustments need to be made based on the unbound drug levels. Okay, so first is increase in volume of distribution and what are its effects. Okay, now second, drug clearance. Okay, what causes the changes in the drug clearance? First, because of the sepsis, there is impaired perfusion of the peripheral organs, especially your GI tract and your kidneys, hindering your drug absorption as well as elimination. Second, there is also reduction in the hepatic blood flow, which may lead to decrease in the drug metabolism. Okay, so when the drug metabolism is decreased, clearance also will be decreased. Third important thing, in the early stages of your sepsis, the most important concept, your augmented renal clearance. So in such cases, if you give a normal dose of antibiotics, that would not be sufficient for this patient. Okay, so augmented renal clearance is one of the factor. Third, if the patient has underlying acute kidney injury or chronic kidney disease, then the drug clearance will be hampered. And the fifth one is your extracorporeal therapy. So what happens in extracorporeal therapies, I will discuss in the coming slides. So why is the altered drug clearance we are worried about? Because it is a key determinant of your maintenance dose adjustments in critically ill patients. So accordingly, depending upon the clearance of the drug, you are going to adjust your maintenance doses. Okay, so this is the second one. Third, changes in drug absorption. Okay, so drug absorption changes, usually this occurs if you're giving the drugs, antibiotics orally. So your oral antibiotics will be affected here. So critical illnesses may affect the GIT and lead to decrease in intestinal peristalsis, mucosal impairment, and altered drug metabolism. So enteric drug absorption and availability are very difficult to predict in such cases because there will be a lot of fluctuations in your gastric pH, loss of enteric architecture, and decreased enzymatic activity. In addition, all of the septic patients have delay in gastric emptying. Okay, so this may affect the oral antibiotics which we give in the ICU. Example includes your oral ciprofloxacin. Now, fourth is the change in tissue penetration. So, the transport of antibiotics to the tissues and subsequently within the tissues, it depends on factors such as the characteristic of the drug, the patient characteristics, what is the disease severity, and what is the target tissue that you need to attack or the drug need to attack. So, but what happens in sepsis? Sepsis, there is significant impairment in your microcirculatory blood flow because there is a lot of endothelial dysfunction, there is presence of microthrombi. So when this occurs, it decreases the tissue perfusion. So whenever you give a drug and your tissue perfusion is reduced, so what happens? There will be a suboptimal antibiotic exposure at the site of infection, the target site. So there will be a potential therapeutic failure, emergence of resistance, and higher morbidity. Okay, so this is the fourth change. Now, what happens in the extracorporeal therapies? Changes. Okay, so the ECMO circuit can sequester the drugs, can alter the apparent volume of distribution, and can affect the drug clearance. How does it do? We'll see. So, first, as I told, sequestration of the drugs. So, the degree of drug sequestration in the ECMO circuit, it mainly depends on the physiochemical properties of the drug, and the important thing is the circuit factors. Okay, so it depends upon the membrane surface area, the type of tubing which you are using, what is the oxygenator which you are using, and the priming solution. Now, as I told, it will alter the volume of distribution. So the changes in the volume of distributions are influenced by your drug sequestration and the hemodilution from the priming solution. So both of it will cause increased volume of distribution. Then drug clearance. It is usually decreased in ECMO because of reduced renal as well as hepatic perfusion. And almost 50% of those patients who are receiving ECMO will also require RRT. So presence of two extracorporeal circuits further adds to the complexity of the drug's pharmacokinetics. Okay, so these are the 5 important pathophysiological alterations which are seen in ICU patients. Now, how to deal with this is very important. So, the applying PKPD approaches to optimize the antimicrobial therapy. Okay, so PK/PD targets can be expressed as, I think everyone knows about this, the Cmax by MIC, time above MIC, or the area under the curve, depending upon whether the antibiotic is dose dependent, time dependent, or AUC dependent killing. Okay, so everyone knows this graph. Try to put this graph, and if possible, try to mention the drugs which are time dependent, concentration dependent, or AUC dependent killing. Now, as I told, how to approach to optimize the antimicrobial therapy. The first approach is try to increase your loading doses. Okay, as I told, most of the antibiotics causes increased volume of the volume of distribution is increased in sepsis, right? So as the volume of distribution of antibiotics is often increased in sepsis, a higher loading doses are needed for hydrophilic antimicrobials. Which are these? Your beta lactams, vancomycin, aminoglycosides, and colistin, to achieve a similar and adequate therapeutic concentrations. Okay, so they have tried some new regimes. Okay, so some new optimal beta lactam loading doses have been suggested. Like for piptas, the loading dose is 8 grams in 3 hours. For ceftazidime, 4 gram in 3 hours. Cefepime, ceftazidime and cefepime. For meropenem, it is 2 gram in half an hour. Okay, which is based on population PK analysis and Monte Carlo simulations. Okay, but these are just suggested, it's not been followed yet. Okay, so they have done a lot of analysis in this pharmacokinetics, and they have proposed that for septic patients, try to give high loading dose. And the loading dose should not be altered in patients with renal impairment or those receiving RRT. We all know we give the full dose of antibiotic loading dose in AKI, CKD, or RRT patients. Now, optimal mode of administration of antibiotics. So in that, the first is your continuous infusion mode. So a lot of debate is been going on whether antibiotics, especially your beta-lactam, to be given as an intermittent dose or a continuous infusion. So most of the studies have shown that continuous infusion mode has improved outcomes, including a higher rate of PK/PD target achievement, higher clinical remission rates, and superior microbiological eradication. So especially this has been tried with beta-lactam antibiotics. Previously, some meta-analysis have demonstrated no superiority by giving a continuous beta-lactam antibiotics in terms of survival. So recently you have your Blink trial. So Blink 3 trial is important for you all. So here they compared outcomes between continuous and intermittent infusions of beta-lactam antibiotics in 7,000 patients. Okay, so a very huge number, but they found there is no statistical difference in all-cause mortality at 90 days. So if you see here, so this is your Blink 3 trial. So 7,000, nearly 7,000 patients, 3,500 in continuous infusion and the remaining 3,000 in intermittent infusion. This continuous infusion was given over 24 hours of either peptaz or meropenem, whereas in intermittent over 30 minutes. Okay, and the primary outcome was all-cause mortality within 90 days after randomization. And if you see, there is no statistical difference between the two groups. But this was a primary outcome. But when you come to the secondary outcome, if you see the clinical cure rate at day 14, okay, it is statistical significant. So it is better with continuous infusions. Okay, so this is about the Blink 3 trial. Now, they've also tried continuous infusions for non-beta lactam antibiotics, especially linezolid. Okay, these are only observational studies, and this showed that continuous infusion of linezolid was associated with improved alveolar diffusion and better clinical outcomes in terms of clinical improvement and mortality. But still, RCTs are lacking. So whether to give still continuous infusion or intermittent infusion is still in doubt. But if you want a better antibiotic delivery, then continuous infusions are a better option. Now that was the first move. The second is your inhaled antibiotics. Okay, so inhaled antibiotics have emerged as a potential means of treating your pulmonary infections with limiting the emergence of MDR strains. So a lot of meta-analysis has been done on this, and they have shown that there is significant higher rates of clinical recovery, which is statistically significant. Okay, when you're giving inhaled antibiotics, and the microbiological eradication was also statistically significant, with no difference in terms of mortality or risk of nephrotoxicity. So as such, there is no mortality benefit, but clinical recovery and microbiological eradication are better when you give IV plus inhaled antibiotics. Okay, there are two recent RCTs. These two RCTs you need to remember. I have already, next I'll be discussing about inhaled antibiotics. So there I have told about your inhale trial. So inhale and vaporized trials. So they assess the efficacy of your inhaled antibiotics, aminoglycosides and fosfomycin as an adjuvant therapy, and they failed to demonstrate any benefit of the inhaled route over the standard of care IV administration in the treatment of gram-negative bacteria-related VAP. Okay, so initially there was a huge use of inhaled antibiotics, but now recent trials are showing that as an adjunct therapy they use this. So whether if they used as a standard therapy, whether it will help or what, we need to see. Now, third measure for an appropriate antibiotic dosing and to prevent side effect is your therapeutic drug monitoring and dosing software. Okay, so dosing normograms and therapeutic drug monitoring had initially been introduced as pioneering solutions for optimizing drug dosages. Okay, so therapeutic, first we'll discuss about therapeutic drug monitoring, and second we will discuss about this normograms or the use of AI here. Okay, so therapeutic drug monitoring is the process of measuring a drug's concentration in a patient's blood to optimize the dosing. So it is most beneficial for those drugs which have a narrow therapeutic window, high pharmacokinetic variability, and for which a clear relationship between blood concentration and clinical effect exists. Examples for which therapeutic drug monitoring has to be done are your beta-lactam antibiotics like piptaz, meropenem, vancomycin, aminoglycosides, and in antifungals, the voriconazole. The other drugs where therapeutic drug monitoring are required are your immunosuppressants, your tacrolimus, and your anti-seizure medications. The second one, which I was talking about, dosing normograms. So a new or a innovative approach has been introduced now. That is nothing but the MIPD, that is model informed precision dosing. Okay, so what is this model informed precision dosing? It is a strategy in personalized medicine which uses mathematical models to determine the optimal drug dosage for an individual patient. So unlike a standard one-size-fits-all approach, this MIDP, it accounts for each patient's specific characteristics to maximize treatment effectiveness while minimizing the side effects. So basically here your AI comes into play. So what does this MIPD do? So it takes into account the clinical characteristics, the dosing history, the labs and biomarkers, and then it makes a model. Okay, model based Bayesian forecasting has been done, and then it determines and it also understands for that particular patient, if suppose there is a renal disease, suppose if there is a liver disease, so it will understand the individual PK/PD of the patient, and then it will determine the optimal dosing regimens. Okay, so this is about the MIPD. Okay, now finally, this is the last slides which tells about the pharmacokinetics. Basically, you should tell the pathophysiology and what are the measures to prevent or what are the measures that are implemented for optimal drug dosing. So the first measure would be your increased loading doses. Second, the mode of drug delivery, where you have your continuous mode and your inhalational mode. And the third one is your MIPD and your therapeutic drug monitoring. Okay, so these are the solutions. Okay, so this is the last slide, which just gives the gist of the class. So in the early initial phase of the sepsis, that is 0 to 24 hours, if you're using the hydrophilic antibiotics, you need to increase the loading doses for both concentration dependent as well as your time dependent antibiotics. Suppose if you're using any lipophilic drugs, then weight based loading doses has to be done for obese patients. Okay. Next, in the next 24 to 48 hours, which is known as early maintenance phase, you need to consider continuous or prolonged infusions for time dependent drugs. And you need to adjust drug dosing to renal function, especially for your hydrophilic drugs. So use measured creatinine clearance, use higher dosing in ARC, and use extended dosing intervals for concentration dependent drugs. Suppose if it is a lipophilic drug, you need to adjust the drug dosing to hepatic function and consider reduced dosing in cases of severe cirrhosis. And for all the other drugs, wherever possible, use your TDMs or your dosing normograms. Now, late maintenance phase, which is more than 48 hours, same for the hydrophilic drugs, you need to adjust the drug dosing according to your renal function. And suppose if the patient is on CRRT, then try to adjust the dose according to your effluent rate. For the lipophilic drugs, it is same. Adjust for the hepatic function, and if suppose the patient is on ECMO, then you need to adjust the doses accordingly. Okay. So this is nothing but this one. If you put it in the exam, the examiner will be happy. Okay. So this completes your PK/PD of antibiotics. So next comes your inhaled or the aerosolized antibiotics. So we all know that lower respiratory tract infections are a leading cause of morbidity and mortality, and antibiotic resistance complicates the treatment. So why we require inhaled antibiotics? What are the challenges in the current treatment with this IV antibiotics? So high dose IV antibiotics are needed to treat any severe infections, especially your MDR infections, but all these drugs have a limited lung penetration. As I told, tissue penetration is low in sepsis, right? That is first. Second, so in LRTIs, most of the bacteria, or if the patient is intubated, especially in a VAP, there is formation of the biofilm. So this biofilm formation, it makes bacteria up to more than 1,000 times resistant to the IV antibiotics which we give. Third, the risk of systemic toxicity, liver toxicity, renal toxicity. So that is more with IV antibiotics, and limited success with existing antibiotics. So a lot of resistance has been developed to lots of IV antibiotics. So these are the challenges which we are facing now. So what are the advantages if you give a inhaled antibiotic? The first is, a very important one is, delivery of high doses of antibiotics directly to the lung, as local antibiotic concentrations are many-fold higher than your minimum inhibitory concentration of the causative pathogen. So local concentration of the antibiotic is high. Second, there is limited emergence of MDR bacteria when you give it locally. Okay, that has been proved in your IASIS trial. Third, limits nephrotoxicity of aminoglycosides and colistin. It doesn't avoid completely, but it limits the side effects. Fourth, when used as an adjuvant therapy, it decreases the duration of systemic therapy. Okay, so in other words, it has a role in antibiotic stewardship. And if used as a prophylaxis, it may reduce antibiotic selection pressure for MDR organisms. So these are the advantages of your inhaled antibiotics. Now coming to the indications. So as I told, it can be used prophylactically in those patients who are at risk for developing your MDR organisms. Second, it can be used as a salvage therapy in cases of failed systemic treatment. Okay, so that there is eradication of colonization, and in those who are at risk of developing AKI where you can't give your systemic antibiotics, you can try inhaled antibiotics. Third, in a documented infection, when you when there is a failed IV antibiotics, then you can try inhaled antibiotics. Okay, and in severe cap or nosocomial infections, and especially in immunocompromised patients, if there is any severe degree of bacterial pneumonia, if the patient has an underlying bronchiectasis, bronchitis, PCP pneumonia, or TB, you can try your inhaled antibiotics. Okay. No, it's not easy for all the drugs to be given in the aerosol form, right? So, what are the ideal properties of the antibiotics for aerosol therapy? So, the first thing is the agent should be soluble in the solution, right? It should be mixed solution, and it should be able to be delivered as an aerosol. Second, it should kill bacteria in a concentration dependent fashion. It should remain active in the lung and not be degraded by any of the delivery processes. And it can penetrate into sputum and lung secretions or the biofilms that are present. It should have minimal systemic absorption, so thus minimizing some of the toxicity that occurs with systemic administration. And importantly, it should not be injurious to the airway surface. And ideally, it is an antibiotic that does not ordinarily reach high levels in the lung with systemic administration. It should be preservative free, and the particle size should be 3 to 5 microns. So these are the ideal properties. Okay. Now, what are the patient factors which will influence the delivery? That is also very important. Not only the drug, patient is also important. So, what is the degree of the baseline underlying airway and parenchymal lung disease which the patient has? Second, what is the type of pneumonia, whether it is consolidated versus bronchopneumonia? And important, how do you deliver it? So the tidal volume used and the mode of mechanical ventilation and ventilator settings, especially if the patients are, you're treating it for the VAP. Okay. So in short, this is the best diagram to see what will influence your drug delivery in aerosol antibiotics. So one is ventilator settings are important for us. Okay. Drug characteristics and the loaded dose, ventilator patient interface, what is the type of nebulizer that you are using and where is its position, what is the droplet size, what is the targeted lung concentration, and your heat and humidification. So all these matters. Now, as I told about the nebulizer here. So what type of nebulizer has to be used and where it has to be placed. This is very, very important. Okay. So there are three types of nebulizers. So you will not be able to achieve a proper drug concentration if you are using a normal nebulizer which is present in your ICU. So you need some specialized nebulizers like your ultrasonic nebulizer, jet nebulizer, or the vibrating mesh. Among these three, which is the best one? It is the vibrating mesh. Why vibrating mesh? Because here the particle size is less than 5 micron, and when you give a drug through this, around 60% reaches the patient. There is no heating of solution during administration, which is usually seen with the other two. And it leaves the least amount of residual volume. So nearly 80 to 90% of the volume will be taken into the patient. That's why vibrating mesh is a better nebulizer to give an inhaled antibiotic. Okay, so these are the other things, your ventilatory settings. What should be your ventilated setting? That is also very, very important. So your tidal volume should be maximum 8 ml when you're giving. Okay, your respiratory rate should be 12. Inspiratory flow should be less than 30, and hence expiratory pause of around 20%. This is the ideal settings, but I think most of them might not follow this. And next is about the position. Where to place the nebulizer is a very important thing. Okay. So one important thing is when you are giving nebulizations, you when you're using a heat and HME filter, you need to remove it. Okay, otherwise all your drug will go to this. Okay, so nothing will go to the patient here. So you need to remove and then give the nebulization. And once you finish the nebulization, reconnect it back. Okay, now they're told that three important positions can be used. If you see here, A, B, and C. So this is the ventilator. So here you will be having one of your filter, HME filter in the expiratory limb, and in the inspiratory limb, you will be having a heated humidifier. Okay, so three positions. So position A is in the inspiratory limb at the Y piece. So this is the Y piece. So at the inspiratory limb near the Y piece is the first position. Second position is, this is the ideal position, which is 20 to 40 centimeters from the Y piece. Okay, so from the Y piece, 20 to 40 centimeters away in the inspiratory limb. And third is the C position. This is also same in the inspiratory limb, but at the ventilator outlet. So this is the ventilator at the ventilator outlet. So ideal position is your B1. Okay, but what happens is this position is impractical on a standard commercial circuits. Okay, placing this is not so practical. So you can either consider your A or C. If you're considering the C, if a heated humidifier is used, you need to keep it on during the nebulization. Okay, so this is a position and what has to be done. Remove your HME filter. If there is a heated humidifier, keep it on, and it should be placed in A, B, C in the inspiratory limb. Okay. Now, what are the drugs that can be given in the inhaled form? Okay, so if you see, there are a list of drugs. A lot of drugs can be given. A lot of antibiotics, not drugs, sorry, antibiotics. A lot of antibiotics can be given. So the indications will vary. For cystic, this is for cystic fibrosis. This is non-cystic fibrosis bronchiectasis. And for us as an intensivist, this is important for VAP. So for VAP, what are the drugs that can be used? So in the aminoglycosides, gentamicin and amikacin. Okay. Then polymyxin, colistin, most common. So what we use is amikacin and colistin most commonly. Okay. Vancomycin can be used and ceftazidime can be used. Okay. So these are the drugs that can be used for VAP. Now coming to the doses, I will tell you in the last. So what are the side effects? Okay. So these inhaled antibiotics also have some side effects. Like as I told, it can limit the nephrotoxicity or systemic toxicity, but cannot prevent it. So some amount of systemic absorption happens. So a chance of nephrotoxicity is present when you use your aminoglycosides and your colistin. Coming to the local effects. So there could be some airway irritation or inflammation more with colistin, and if the patient is spontaneous ventilation, cough could be present, bronchospasm, wheezing, desaturation and hypoxemia, obstruction of the ventilator circuit, hypersensitivity pneumonitis, and in some cases, rarely even hemoptysis. And why this desaturation or hypoxemia happens? Because of the repeated disconnection from the ventilator, which leads to derecruitment in ARDS patients. Also, there is some amount of infection that is associated with these inhaled antibiotics when you give it. Okay. So now coming to evidence. So what are the guidelines telling whether we can use inhaled antibiotics or not? Okay, so your IDSA ATS guidelines 2016 has a weak recommendation and a very low quality of evidence for the use of inhaled antibiotics. So what did they tell? So for patients with VAP due to GNB that are susceptible to only aminoglycosides or polymyxins, we suggest both inhaled as well as systemic antibiotics rather than systemic antibiotics alone. But it is a weak recommendation. Now coming to the European guidelines. So 2017 European guidelines tell that better to avoid the use of nebulized antibiotics as either adjunctive or substitution therapy, or in infection with either resistor or sensitive organisms. Anywhere, they are telling just avoid nebulized antibiotics. Okay. So this is one of the other way of representing the indications. So healthcare associated lower respiratory tract infection. What we have discussed was about the VAP and all. Now what is about the healthcare associated, any healthcare associated lower respiratory tract infection? So, so how does it progress? First, no bacterial colonization, then tracheobronchial colonization, tracheobronchitis, then VAP, that is the first episode of VAP, and failure of the first line of IV therapy. Now, for the initial three categories, so preventive inhaled antibiotics to avoid VAP occurrence can be given. So the green color indicates yes, you can give. The first episode of VAP, before giving your IV antibiotics, there is no indication. But VAP or ventilated HAP after failure of your first line intravenous therapy, adjunctive or standalone rescue inhaled antibiotics may be considered in selected patient, but their use is not supported by high level evidence. That's why it is orange. Okay. Now, I told there are some trials, right? So I have discussed about the inhale and vapor trial. So inhale trial, as I told, there is no difference in mortality. There are some other trials which have done on amikacin, fosfomycin. Here it is amikacin. Okay. So important is your inhale trial where it showed no difference in mortality. And what is the dose? What is the dose of amikacin that has to be given as aerosol therapy and colistin? For amikacin, it is 400 mg BD. Okay, whereas for colistin, they actually give it in mg. So 75 mg BD, that nearly comes up to 1 million units BD. Okay, so 1 million unit is equal to 80 mg. Okay, so 75 mg means nearly it is 1 million unit. So 1 million unit BD is the dose for inhaled antibiotics and inhaled colistin. Okay, so this completes your second topic. Now coming to the third topic, fungal biomarkers. Okay. So invasive fungal infections are a major cause of morbidity and mortality. Hence, early diagnosis is very crucial to have a better patient outcomes. So biomarkers, they provide rapid and non-culture based diagnostic tools. We all know that fungus takes a lot of time to be cultured. So biomarkers will help for a earlier diagnosis of the invasive fungal infections. So why biomarkers? Because your traditional culture methods are slow and insensitive, imaging often is non-specific, and your biomarkers will actually aid in early and accurate detection. That is the reason biomarkers are important in diagnosing the invasive fungal infections. So what are the key biomarkers? One is your galactomannan assay. Second, your 1,3-beta-D glucan. Third, mannan antigen and anti-mannan antibodies. PCR based assays, and your CRAG, cryptococcal antigen. Okay, so we'll discuss one by one. So first, at least you should know in detail about your galactomannan and beta-D glucan. So galactomannan, so it is a heat stable polysaccharide that is a component of the cell wall of your Aspergillus species. So it is released during active fungal growth and tissue invasion. Small amounts may also be released by Penicillium and some other molds, but it is most clinically relevant for invasive aspergillosis. So what is the principle of assay? It is based on your ELISA method. So whatever the galactomannan assay is, it is a ELISA method. Okay. So what are the samples that can be sent? So most common is your serum, which is minimally invasive. But if the patient has a pulmonary infections, then BAL fluid can be sent, and it has a higher sensitivity in pulmonary aspergillosis. And if you're suspecting a CNS aspergillosis, you can also send your CSF. So galactomannan can be done in serum, BAL, and CSF. Okay. Now coming to the interpretation. Okay. So usually the results are expressed as ODI, that is optical density index. Okay. So when your serum galactomannan assay if the value comes more than or equal to 0.5, that is considered positive. It varies according to the guidelines. It's not fixed. Similarly, BAL, if it is more than or equal to 1, that is considered positive. But these values should be interpreted in context with your clinical findings and imaging. Okay. Now, what is the clinical utility? So it helps in diagnosis, it helps in monitoring of the disease, and also helpful in epidemiology purposes. So diagnosis helps in early detection of invasive aspergillosis, especially in high-risk patients, like your hematological malignancy, stem cell transplant, solid organ transplant, or prolonged neutropenic patients. Because if you delay treatment in these patients, they may land up in complications. Monitoring. So galactomannan assay levels may decrease with effective antifungal therapy. So in order to see whether the patient is improving or not, you can do your galactomannan assay. And it's used epidemiologically in clinical trials and surveillance. Now coming to the sensitivity and specificity. So sensitivity is around 70 to 90%, but for BAL, the sensitivity is still higher. Specificity is around 80 to 90%, and the performance, it depends on the site of infection, the host immune status, and the type of sample that you send. What are the limitations with galactomannan assay? So we all know there are lots of false positive and false negative results with galactomannan. So what are the false positive? So certain antibiotics like earlier use of piptaz, amoxiclav can result in a positive galactomannan assay. Okay. Otherwise, the second is a cross reactivity with either fungus like Penicillium, Histoplasma, Fusarium. Okay. And this can usually happen from contamination from the foods. Third is any cotton contamination can also result in positive galactomannan assay, and a prior treatment with cyclophosphamide. In some case reports, they showed that your galactomannan assay is positive. This is about the false positive results. Now coming to the false negative results. So suppose if you're sending it in the early infection with a very low antigen burden, or if the patient is already on antifungal prophylaxis or therapy, or if the infection is a localized infection without a bloodstream dissemination, and presence of any anti-aspergillus antibodies. In all these conditions, you will get a false negative results. Now, what does the guideline recommend about the use of your galactomannan? Your IDSA and your EORTC, it includes galactomannan as a mycological criterion for probable invasive aspergillosis. What is this? I'm going to discuss in your next topic. And it is recommended as a part of diagnostic workup in high-risk population, especially your hematology or oncology patients. Now that was about your galactomannan. Now comes your 1,3-beta-D-glucan. So this is a polysaccharide cell wall component of many fungi. So that is only for Aspergillus galactomannan, but this 1,3-beta-glucan can be present in most of the fungi. So it is released into the bloodstream during invasive fungal infections, and it is present in, as I told, many fungus, Candida, Aspergillus, Fusarium, Pneumocystis, and other molds. But it is absent in your Cryptococcus and your Mucor. Okay, so 1,3-beta-D-glucan will not be positive in your cryptococcal infections nor your Mucor. Okay. So samples most commonly you going to send serum. The cutoffs, so if it is more than or equal to 80 picogram per ml, then it is positive. 60 to 79 intermediate, and if it is less than 60, it is a negative result. And results are quantitative, giving fungal load estimation. So how severe is the fungal load, we will be able to know with this. Okay. Now what is the clinical utility? So broad spectrum screening test for all the types of invasive fungal infections, and especially used in immunocompromised patients. Like your hematology already I've discussed, and ICU patient at risk of candidemia or aspergillosis, and also in the diagnosis of PCP pneumonia you can use this, because that forms the cell wall component in PCP also. Now, sensitivity and specificity varies according to the fungus that is present. So I don't want to discuss in detail. So, but it has a very high sensitivity for your PCP pneumonia. It is better when used serially rather than a single test. Now, what are the limitations and the false results with this? So, the false positives are usually seen with hemodialysis patients because it contains some cellulose membranes. So, it might come as a positive results. If the patient has a recent IV immunoglobulin therapy, certain antibiotics, severe bacterial sepsis. Okay, because gram positive and gram negative bacteria release your BDG like polysaccharides. So, severe infections may cause false positive results and any gauze contamination. Okay, so all these cause false positive results. False negative, cryptococcus and your mucorales, which I have already told, and early infection or any localized disease. So this is also recognized by your EORTC MSG criteria as a mycological criterion for the diagnosis of invasive fungal infections. It is recommended as an adjunct tool, but not as a standalone tool. And it is best used in combination with your galactomannan and or a PCR for a higher diagnostic accuracy because it is positive in most of the fungus. So you use it either with a galactomannan so that you can diagnose aspergillus, and if a PCR is present, use along with that, but not as a standalone diagnostic test. Now, third comes your mannan antigen and anti-mannan antibodies. So, mannan is also a component of the cell wall of your Candida species, and it is very specific for your invasive candidiasis. And this anti-mannan antibodies are produced by the immune system in response to fungal mannan. So, the presence and levels of these antibodies indicate the host's immune response to the fungal infection. So sensitivity is improved when you do both mannan antigen and anti-monan antibodies. And if both are present, then your sensitivity is improved for diagnosing your invasive candidiasis. Now next comes your PCR-based assays. So usually these PCR-based assays, they detect the fungal DNA in blood, ball and tissue rapidly and more sensitively compared to your traditional methods like cultures. So you have two types, pan-fungal assays and species-specific assays. Okay, and the advantages are, so you can identify difficult to culture fungi. It detects, one more thing is, additionally it detects antifungal resistant genes also. And it guides antifungal therapy in high-risk patient. Disadvantages are inefficient DNA extraction, human DNA inhibition, and a lack of standardized protocols hinder widespread clinical adoption. Now, the last one is your cryptococcal antigen crack. So most commonly we do it in a HIV positive patients. So this detects the capsular polysaccharide of Cryptococcus species. So it is basically a point of care test. So CRAG you will get the results within minutes because it's a point of care test, and the method is your lateral flow assay, which provides results in minutes for diagnosing your cryptococcal infections. And if you come to the sensitivity and specificity, it is very specific and sensitive, 92 to 98%. And you can do this test in both serum and CSF, and it is a preferred test for cryptococcal meningitis. Now, biomarkers by pathogen. So, if it is an aspergillus, so what biomarkers can be used? One is your galactomannan, your beta-D-glucan, and the PCRs. Suppose if it is a candida, you can't use galactomannan because it's only specific to aspergillus. So, you can use your beta-D-glucan. As I told, mannan and anti-mannan are very specific for invasive candidiasis, and your PCR. If it is a cryptococcus, only CRAG, and for pneumocystis, you can use your BDG and the PCR. What are the limitations of biomarkers? So we have seen limitations, a lot of false positive and false negative results are present, and it's not universally available. Some of the hospitals still don't do this galactomannan assay, or it is outsourced. So it's not universally available and best used in combination with clinical and imaging findings. So standalone test for diagnosing it would be a difficult task. So sensitivity I've already discussed. So the future directions for the biomarkers. So there is something known as multiplex biomarker panel. So 2 to 3 biomarkers together in one panel, or it is integrated with next generation sequencing, point of care diagnostics like CRAG, if any other new thing for the diagnosis of your aspergillus or candida, and personalized antifungal uh, therapies. Okay, so this completes your fungal biomarkers.